Hello everyone, I'm Lindsay Joseph, the LINKS Program Officer, and I would like to welcome you all to the April LINKS webinar. Just a few housekeeping rules before we get started. The lecture will be 30 minutes long, followed by a Q&A session. We encourage participants to use the Q&A button to ask questions. The Q&A button is located at the bottom of your screen. Participants will be on mute and have the option to unmute themselves during the Q&A portion of the presentation. This webinar is being recorded and will be posted to linkscommunity.org. Now I'll hand it over to Dr. Tom Frieden, President and CEO of Resolve to Save Lives, to introduce the topic and today's speaker.
Hello everyone, and welcome to this webinar. LINKS is a community helping to build the collaboration among countries and individuals around the world to advance cardiovascular prevention. It's a collaboration among Resolve to Save Lives, the World Health Organization, and the Centers for Disease Control and Prevention. It's an online community and resource sharing platform for people working to improve die from high blood pressure more than from all infectious diseases combined. We work with global, national, and local partners to help establish and scale up proven strategies to improve control of high blood pressure. Hypertension is the leading cause of stroke, and in fact, in the U.S., is a leading cause of stroke, I should say. In the U.S., stroke kills about 140,000 people each year. As outlined in the Healthy Lifestyle Counseling, or H module of the WHO Hearts Technical Package, behavioral factors such as unhealthy diet and inadequate physical activity, coupled with metabolic risk factors such as high blood pressure, lead to heart attacks and strokes. Interventions with a culturally tailored behavior change component, in addition to hypertension management and treatment, may be successful in improving cardiovascular health. It's important that we recognize that lifestyle management and medication treatment are not either or. The optimal treatment will, for most patients, involve both lifestyle management and medication. And while we focus in our hypertension treatment program on the underuse of medications, we also hope to see more effective implementation of lifestyle management programs. Today's presenter is Dr. Olahide Williams, an associate professor of neurology at Columbia University and the founder of Hip Hop Public Health, a nonprofit that works to create culturally tailored, evidence-based health literacy music and media for children and families. He'll discuss the impact of community education on stroke risk and child-to-adult communication as a means of promoting cardiovascular health. I'll now hand it over to Dr. Williams.
Good afternoon, everyone. I'm delighted to be joining you for this webinar, and I look forward to answering your questions, hopefully, at the end of my talk. Can I have the first slide, please? Next slide, please. So a question that I was confronted with is how do we create health education and health promotion interventions around behavior change for the youth? And so one thing that we realized as we embarked on this journey was that human attention truly has become and has also been described as one of the most precious commodities of our current age. And in our opinion, health education and promotion efforts may have a competitive disadvantage in this attention economy. And so we try to view public health as a service industry seeking to sell and scale a product, only in this case, the product that we are trying to sell is health. And so we developed and published recently a framework that's called the multisensory, multi-level health education framework that leverages art, culture, and science equally across as many socio-ecological levels of behavioral influence as possible, as outlined in the socio-ecological module that you see here. You know, those unfamiliar with these levels of behavioral influence, they consist of both downstream related factors as well as more upstream factors, the individual level factors, interpersonal level factors, organizational level factors, community, and then policy level factors. And so we believe it's important to conceptualize these interventions, even health education and health promotion interventions within this framework, this socio-ecological framework, in order to fully to derive the greatest impact from these interventions as possible. Next slide. So we really focus on two basic principles. And the first is that just giving people information is not sufficient, although it is important depending on how we deliver this information. And the second is that just giving people access is important, but not enough. In addition to access, it's also important to make the healthy choice the easiest choice from both a cognitive, social, and or emotional perspective for it to become the default choice. Next slide, please. And so when one reviews the behavioral science, behavioral change science, there are a few things that really need emphasis. And first is the general communication approaches that are utilized need to be thought through rigorously, and I will go through some of those in a minute. The second is to make sure we not only emphasize the perceived benefits, but we also build self-efficacy. That is the knowledge and the skills required to carry out this behavior. And the third, it's important for us to tailor our strategies, our interventional strategies, as best as possible to the trans-theoretical stage of change that the group or individual is at. And for those unfamiliar with these stages, there are 6 of them, with the pre-contemplation stage, which is individuals with no intention of making the change. There are conscious, and what the pre-contemplation really requires a focus on awareness, raising consciousness. Those are the types of strategies that are required at the pre-contemplation phase. And then at the contemplation phase, those are individuals that have thought about it, but they don't have any immediate plans to engage in the behavior. And the preparatory phase are those planning for change. And then you have the action, maintenance, and termination phases. But as we consider designing our interventions, tailoring them to these stages of change, it's also critically important for us to consider habit-forming approaches as well as habit-disrupting approaches. Now, it is well known that many behavior change interventions increase knowledge and intention to engage in a healthy behavior. In fact, some even demonstrate behavior change. Unfortunately, though, there is what is known as a triangular relapse pattern, which is an initial spike in the healthy behavior during or in the immediate aftermath of the intervention, followed by a decline back to baseline, which usually occurs over time, regardless of the intervention, including those interventions that provide economic incentives, such as free gym memberships. We still see that decline. And it's important to note that these failures, this decline, should not be viewed as just the failure of willpower, but as a failure of creating desired habits, the failure of transforming that behavior into a habitual activity. The key word is habit. And there are certain factors that have been shown to sustain these behaviors. And these factors fall into 2 broad groups. And those are the habit-forming factors and the habit-disrupting factors. Just as an example, if you remember the anti-smoking campaigns, Dr. Frieden really led these efforts. They work not simply because of knowledge and motivation and self-control and willpower, although these new habit-forming intervention components are important, but it also works through old habit breaking old habits. And components that can do this include things like targeting cigarette purchases and environmental cues through some of the policies that were enacted. And so behavior change must include a combination of both creating new habits as well as breaking old ones. And some of the habit-forming interventions that have been shown to be effective include those that include frequent repetition, those that leverage context response associations, recurring contexts and associated cues and nudges, and those that also include intermittent rewards. It's important to just point out here that not only financial rewards, but just the reward of having someone else's approval. And reward science has shown us that those that work best often are those that promote a specific behavior contributing to habit formation. In fact, rewards are the best rewards are those that are not only powerful enough to promote a behavior, but uncertain in the sense that they don't always occur, random intermittent rewards. And this is the science behind the success of slot machines and even more recently, social media accounts. These rewards really do trigger pathways in the brain that are actually the same pathways that are triggered by drugs like cocaine. And so a combination of repetition, association cues and contexts, nudges, and rewards have been shown to really promote habit forming. Habit disruption is also important to implement for sustained behavior change. And there are some cues to disruption that one can capitalize on, such as life events. Having a new child might be a moment where you want to implement a new behavior, a new home, a new job, even what we refer to as the teachable moment. When an individual is sick in the hospital, those are also opportunities for cue disruption. And then environmental re-engineering is very, very important. Those example is like the smoking ban that I mentioned, but also simple things like choice architecture plays an important role. Positive environmental visual cues. In the healthy eating domain, they have bundled healthy foods into fast food options, for example, and some bike share programs have also been shown to be part of this re-engineering that has been shown to be successful. And then vigilant monitoring is also important. Next slide, please. And so the multi-sensory, multi-level health education model tries to leverage art and culture and science. Some of the artistic subdomains include those related to aesthetics and multi-sensory approaches. Examples are the use of music, storytelling, gamification, for example, animation, and these have very specific functions, not only including immersion and motivation, but overcoming literacy barriers. And there is also some data around learning. And these act at both the individual and the interpersonal level of the socio-ecological model. Culture is very, very important. This is a global audience that I'm speaking to, so the importance of cultural tailoring cannot be overemphasized. It's critically important to consider the social norms and also the digital culture of the target group. Examples are through the use of strategies to help improve the cultural tailoring or cultural sensitivity includes conducting qualitative research and cultural adaptation frameworks that can be used, as well as digital culture through the use, leveraging digital culture through the use of social media, etc. These serve to increase cultural relevance and personal relevance and can increase acceptance for the intervention. And these act at multiple levels of the socio-ecological model. Next slide, please. Science, that's really about the evidence behind the intervention, as the design of the intervention, best practices leveraged of the intervention, but it's also important within the scientific domain to consider the cognitive strategies that are utilized within the intervention itself. We spent a lot of time focusing on the cognitive strategies and the cognitive barriers to facilitate learning, retention, and diffusion. And there are certain principles around the stickiness of a message and contagiousness of a message that I will touch upon. Next slide. And so some of the things that have been shown to increase message stickiness are things such as making sure that the messages are simple. Unexpected messages also improves encoding. Concrete messages, credible messages, and emotional stories. We know that our working memories are our short-term memories. I refer to them as the brain's post-it notes, and moving things, and they also have a limited capacity. The working memory can only hold about 7 pieces of information at a time. And so what is responsible for encoding these things, such memories into our long-term memories, really depend on 2 processes: the explicit processes, some of which I've mentioned around repetition and simplicity, but as well as the implicit processes, such as emotional storytelling and adding an emotional component to our interventions. Next slide. Next slide, please. So music affects all of us in very powerful and unique ways. It has powerful effects on brain function. It enhances self-awareness as well as the circuits involved in focused thoughts. It enhances our memories. It creates positive associations and even reduces stress, and also has been shown to augment learning. Next slide, please. Music is also inspirational. It can motivate people, individuals, to go that extra mile, but you don't have to have a personal experience with Rocky for it to be memorable. In fact, what most people don't realize is that music occupies more real estate, more regions in our brain than language itself. And this is one of the reasons why it so powerfully activates our auditory, motor, and emotional centers of our neural networks in ways that very few other stimuli can do, which is why we believe that music needs to be leveraged far more within public health interventions. Next slide, please. And hip hop is a very useful tool in this day and age as a musical option for leveraging within public health. Hip hop has surpassed rock and roll as the music's most consumed genre. 25% of all music is now hip hop and R&B, and it has very, very powerful, almost epidemic level proportions of its consumption among the youth. And so we believe, not only due to its attributes, which is the storytelling, rhythm, and rhyme, but we believe that music is very, very well suited for leverage within public health interventions, and hip hop for the youth in the communities that we serve here in New York has been our music of choice. Next slide, please. Cultural tailoring I've already touched upon this, but just to emphasize that there are cultural adaptation frameworks that can be leveraged. I like to use the ecological validity model, and it makes you focus on the 8 elements for adaptation, such as the language, persons, the metaphors, the concepts, even the context, and it makes sure you don't miss some of these nuances as you are culturally adapting that intervention. And cultural sensitivity frameworks do strengthen ecological validity. Next slide, please. Next slide, please. We use a student advisory board for our cultural adaptation because our programs are really directed at the youth. And so we have a group of students on an advisory board it's a 16-member board, and our students guide the program design and implementation. We meet quarterly with them, and they guide our resource development. These are 5th grade students. There's a president, there's a secretary, and they keep their minutes, and they use traditional rules to run their meetings, and they enjoy it very much. But most important is the output from this advisory board has been very instrumental in the shaping of all our interventions that we designed for these specific age group and for these children. Next slide, please. So I'm going to talk now about stroke, and I'm going to tie in the health education models that we've discussed and some of the behavior changes approaches to an intervention that we developed to handle stroke. But just very briefly, I just want to make the point that time is truly brain. The slide on your left shows an ischemic stroke. The two bubbles show a clot that's occluding an atherosclerotic lumen in one patient, and the other bubble is a clot that's occluding a lumen that's clear. The clear lumen could be a young individual with healthy arteries but has atrial fibrillation, and the atherosclerotic lumen is an individual who has atherosclerotic disease and has a clot that's occluding the artery. Now, for every 1 minute that this blockage is allowed to continue, we lose about 1.9 million neurons. Hence the term time is brain. It's a time-dependent process. The CAT scan is shown on the right-hand side, which is a devastating stroke of a patient that did not survive. Next slide. So stroke disparity, unfortunately, is also quite significant. Blacks are twice as likely to die compared to whites, and the incidence is much higher for a first ever stroke among blacks relative to whites. But most importantly is that blacks are less likely to receive acute stroke treatment than their white counterparts. Next slide, please. So I just want to quickly share this beautiful painting of Rembrandt. It's a very famous etching. It's titled The Raising of Lazarus from 1632. And it depicts the raising of Lazarus as was told in the Bible. And in the red bubble, you can see Mary and Martha leaning over Lazarus, amazed by his resurrection. At the time when Jesus walked into the tomb and says, Lazarus, come forth. Van Gogh was in a mental hospital in the 1890s, and he was visited by his brother in St. Remy, and he was suffering at the time from suicidal depression. So his brother sent him this copy of Rembrandt's etching, but Van Gogh was a staunch atheist. However, despite that, this etching captivated him, not from a religious perspective, but from the perspective of being resurrected from his depression, from his suicidal depression. And so this was actually the only religious painting that Van Gogh ever painted. And it depicts, you can see that Jesus has been removed from his painting. It's been moved to the outdoors. But you can see, again, the raising of Lazarus from the death. And many people believe that the face that's painted is a face of Van Gogh, is Van Gogh's face. And it really depicts his longing to be resurrected from his own state of suicidal depression. Next slide, please. And so, you know, I have had patients who, as a result of their stroke, would rather die than live. You know, one patient particularly told me who had lost half of her mind, half of her vision, half of her speech, half of her body, once told me that she would that she was living a living death, and she wished somehow that she could be raised from her living death that was a nightmare. Next slide, please. But what is real and is the Lazarus effect. And so neurologists have coined this effect, which technically means that there is a minimum of 50% improvement in your disability within 24 hours. What I can tell you is that we see complete recovery of patients presenting with the most devastating life-threatening syndromes when we treat them early. This is an angiogram of the blood vessels at the back of the brain. You can see on the left side, there is a blockage where the arrow is. On the right side, we have restored perfusion. The clot has been dissolved. or removed, and the blood flow has been restored. And this is a patient that experiences the Lazarus effect and fully recovers. However, very few patients are able to have benefit from this simply because they don't arrive at the hospital within the 4.5 hours required for our acute stroke treatments, and they become ineligible for treatment because they arrive too late. Next slide, please. And so there are major delays to early hospital arrival that eliminates people from receiving these acute stroke treatments. And most of them occur at the community level. That delays failure to recognize symptoms, failure to call 911 or take the appropriate transportation to the hospital. And as a result, patients arrive beyond that treatment window and fail to benefit and often end up being severely disabled from stroke. And so the question is, how do we get patients to arrive earlier, to recognize these symptoms earlier and act more swiftly in order to benefit from these medications? Next slide, please. And so there are very well-known barriers to acute stroke treatment. And this is just a slide to emphasize that patient delays are responsible for almost 70% of barriers to treatment. And these delays occur in the community phase in the chain of stroke recovery. Next slide, please. And so we help define what we refer to as stroke preparedness. And stroke preparedness is the ability to recognize the cardinal symptoms of stroke, the knowledge of time-dependent availability of clot-buster treatments for stroke, and the behavioral intent to call 911 if one is witnessing a suspected stroke. Next slide. And so we decided to target children. Children were a captive audience. We wanted to test the hypothesis that children can communicate stroke information to their parents. But at the same time, we wanted to begin lifestyle prevention and primordial risk factor modification at an early age, because as we know, risk behaviors begin at early ages. So we wanted to, one, empower children with lifestyle behavioral modification skills and knowledge, and at the same time, utilize these children as conduits of critical stroke information around recognition and action to their parents. Next slide, please. And so again, back to our multi-sensory model, we wanted to harness the art and the culture domains and make sure we apply rigorous designs to whatever intervention that we develop. Next slide, please. Next slide, please. And so we developed the hip-hop stroke model, which, as I mentioned, involves educating children around the symptoms of stroke so that they in turn can educate their parents. And also we have a significant number of grandparents raising young children and a significant number of children being the only ones in the home when a stroke occurs. So we felt it was also important for children not only to be information vectors into the homes, but also to be able to call 911 themselves if they were witnessing a stroke. Next slide, please.
What's up, y'all, ladies and gentlemen? My name is Doug E. Fresh, and I'm here with the Hip Hop Doc. Let's go! Let's go! Stroke, stroke.
So we, as I'm sure many of you did not expect to see this, an artist rapping with a physician about stroke. So we're harnessing some of those principles of stickiness. And so you can see an unexpected approach. Next slide, please.
He don't sound right, then he's doing the show. Sway when he walks, then he's doing the show. Slur when he's talk, then he's doing the show. Call 911, cause it ain't no joke. Now F is for the face, and A is for the arms. S is for the speech, and T is for the time. Time to do what? Call 911. Time to do what? Call 911. F is for the face, and A is for the arms. S is for the speech, and T is for the time. Time to do what? Call 911. And that's the way that the stroke is done. Come on. Everywhere I look.
And you can see the message is very simple. It's based on the implementation intention strategy. If you see this, you do this. And we use acronyms to simplify stroke symptoms, and we teach children these acronyms as well as their parents through their children. Next slide, please. So I will just keep talking until we get the screen back. And so we created a multimedia, level intervention that really leverages the hip hop music through animation, the intervention is delivered to schools, the schools in school or after school programs. It's 3 45-minute modules. It's a multimedia curriculum, 45 minutes, that involves homework activities, which involves logging in to a hip hop stroke portal. The hip hop stroke portal is at hiphopstroke.org. The portal allows access to the modules, and it includes homework activities that are conducted between parents and their children. We had a randomized control trial to test the efficacy of this intervention. And then we found that the intervention was highly effective in improving not only the knowledge of the children, the stroke preparedness of children, and that was not only exemplified by very high stroke preparedness scores using a developed. So we had several children who actually stroke occurring in their homes, grandparents, parents, and were responsible for calling 911, in a couple of cases overruling their parents in that decision-making process. We also found significant increases in stroke preparedness among parents. We had parent stroke preparedness score improved by almost 25%, and we found that this improvement was sustained over 3 months. We also found that the children continued to engage the hip hop stroke tools, the video games and the videos, but particularly the video games. And that resulted in a longitudinal tracking of these students across a 15-month period, during which we saw continued improvement in their stroke preparedness scores. We believe that's because the children were independently re-engaging the media and the materials, because we designed it in a way that was engaging, immersive, and effective, as shown by our randomized trial. We are now in the process of scaling the intervention across New York State. The portal is available globally. All it takes is for individuals to go to the hiphopstroke.org website. There's a demonstration of the program. You can register your school. Once the schools register and create an account, they have access to the modules. The intervention is completely free, and we're in the process of really supporting any group or individual that's interested in culturally adapting it for their sites globally. And so with that, I will be very happy to take questions. I apologize again for the media glitch towards the end, but I believe you had enough of a snippet of some of our media activities. And so thank you very much. Again, I'm very happy to have had this opportunity to speak to all of you. So one of the questions is, why do you think adults are more likely to respond to health behavior change information if their children or grandchildren deliver the message? Well, actually, we took the cue from the Great American Smokeout. One of the things that struck me with the Great American Smokeout is the anecdotal reports of so many adults who stopped smoking because their children really, made them stop smoking. So there are a couple of phenomena. The first is all of us who have children, we call it pester power. But in industry, they call it purchase influence. Children have an incredible ability to influence purchases by their parents, and the marketing and industry has had tremendous success leveraging purchase influence of children. And if you just look at industry and look at how they target children and utilize children to influence purchasing behaviors of children of their parents, and if you look at the success of some of the smoking campaigns, although anecdotally, unfortunately, we didn't have robust publications out of the Great American Smokeout. But if you look at the effect, and then if you translate all that to your own personal behaviors, if those of us who have children, especially children, tweens, those pre-adolescent children, the ones that still require homework help at home, they have tremendous untapped influence, both for communicating information to us. I learned about the Greek mythology through homework with my children, for example. But they also can influence not only our purchasing behaviors, but our actual health behaviors. Because of the type of work that I do and try to promote healthy behaviors and healthy eating, it's very difficult for me, for my children to catch me engaging in unhealthy eating habits because they hold me accountable. And so I believe that children have a role to play through what we refer to as child-mediated health communication in moderating or even changing parental behaviors.
Thanks, Dr. Williams.
Sorry for the technical difficulties, and thank you for being so flexible with your presentation. We appreciate the smoothness of it. A couple of questions have come through. First, what's your suggestion for helping people in Africa and elsewhere where illiteracy is combined with lack of access to medical treatment?
Well, that's a great question. So I'm from Nigeria, and I still do a significant amount of work in Nigeria. And one of the things that we have, at least in a lot of sub-Saharan African countries, is interestingly, social media is still active in these countries. Facebook, Twitter. I was very surprised by the extent of use of social media. But aside from social media, media in general, the radio, television access is a powerful medium through which to begin to address some of those pre-contemplation stages that I mentioned. In Nigeria, for example, we have a very large music industry and a very large, television movie industry as well as music industry. It's called, they call it Nollywood. And some of these artists have such incredible following, such incredible reach. The music is loved by the people. People recite the songs from start to finish. And so we believe that raising awareness, which is really moving people from the pre-contemplation to the contemplation stages, we believe that the music and public health can align on those levels, even within sub-Saharan, even within African countries, and begin to introduce some concepts around health behaviors and public health challenges through the use of music. People are more likely to engage with things that they enjoy and are already familiar with. And these messages coming from the right vehicles and the right artists have the ability to begin to move people into a stage of at least awareness. And so I believe that even within Africa, that music can play an even greater role within public health.
Thank you very much. Do you believe that health messages can also impact complex adult family member behaviors, such as adherence to medication or reduction of salt in food cooked at home, where do you think the limits are on what health messages delivered to children can accomplish for adult family members?
So I believe that what we need are multi-component interventions, and as I mentioned that information alone is insufficient. Without access, if you don't have access to a hospital, knowing the symptoms of stroke is not sufficient. And so I believe in multi-component interventions, multi-level, multi-component interventions. We need to address some of the access-related issues, but I don't want a situation where the emphasis is on the access alone, or the emphasis is on the provision of information alone. I think that we need to do both in a rigorous manner. Just for example, I don't know if there are any people from China on this webinar, but there was a very interesting study in China to reduce sodium consumption, and the study targeted children, and it was a school-based study. I believe it was called the SALT Edu study, and the study targeted salt awareness, salt behaviors, salt usage at the child level, and used a similar framework, child-mediated health communication, to try to have these children encourage their parents when they're cooking to use salt substitutes, and also to remove added salt, those salt shakers, from their tables. So they implemented this at the school level. What was fascinating about this is that they collected 24-hour urinary sodiums. So it wasn't just a self-report assessment of salt behaviors. They looked at 24-hour urinary sodium collection before, after, and delayed beyond the intervention period. And they actually found that just targeting the children, they were able to reduce the parental salt usage in meals and in cooking and in the homes. And that was reflected by reduced urinary sodium excretion at the parental level as well as at the child levels. And so we know that this is an underutilized, untapped strategy. However, saying that, it's also important for us to understand the restrictions and the limitations of this strategy without concurrent efforts to provide access to lower costs and all those other upstream factors that are necessary to maintain behavior change.
Thank you very much. A very important point, that what's needed is a comprehensive program that includes both services as well as the communications aspects of those services. The next question comes from Abuja, Nigeria, noting that the country is very large and it's difficult to reach into the community, especially in villages where there's no electricity. And whether you have any thoughts about what some approaches might be to convey communications messages in a country as wide and diverse as Nigeria.
Well, that's a great question, and there's certain challenges with some of the remote villages, and some very severe challenges with access as well. And this is where the role of paraprofessionals, community health workers, what we call task shifting strategies become effective. Some of my colleagues have done similar work in Ghana. A colleague of mine did a very interesting intervention that included rural areas in Ghana, which was a task shifting intervention, and they were able to shift some of the work, the physician work, to nurses and other paraprofessionals and community health workers for those remote villages, and they found that through those actions, they were able to impact some of the behaviors. But again, even in those situations, it's also important to make sure that medications are available and people have access to medication. That particular study made medications free. Blood pressure medications were free. And so, again, back to the multi-level multi-component needs, It's important for us to be creative in the way we reach these communities through, paraprofessionals, community health workers, task shifting strategies. But it's also important for us to make sure that the things that we prescribe are affordable, and the hospitals and the community centers that these individuals can go to are accessible and affordable.
Two other questions. First, how important is the music? What does music add in this? You've talked about the impact overall, but just wondering whether you think the music is a small or large part of the potential positive impact.
So I think that music is an untapped resource for health communication. If you just remember learning, many of us learned our ABCs through music. Many of us learned about hygiene and so many actions when we were kids, moral behaviors through nursery rhymes. Music has always played a very large role in education, from especially young children. And music, we know, has, as I mentioned before, within the brain, there are more regions dedicated to music than there are language. In fact, what we leverage in patients who have language disorders is a phenomenon called melodic intonation therapy, where we use music to overcome disability from aphasia and language disorders in patients who have strokes. So music really does have untapped, both from a neuroscience perspective, untapped potential for learning and augmenting memory, and creating engagement and immersion. What I believe is that a lot of our public health interventions are not, especially those targeting health education, are not engaging enough, are not emerging enough. And when you combine that with the natural attributes of music to augment learning and facilitate memory, we believe, and which we demonstrate in our studies, that music is an underutilized component in our public health strategies. But again, I want to point out that music is just one component. We subscribe to multi-component interventions if you truly want to impact behaviors in a sustainable manner.
Thank you. And this dovetails nicely with the next question that we received from someone else in Nigeria. For cultural adaptation, would a combination of music and sports among youth be an advantage, especially to reach into the community?
Well, the answer is yes. I'm a believer that if you engage people in the type of, if you engage people sufficiently, then you're more likely to have a greater impact with the intervention. And so, it could be, salsa for Hispanics, or it could be country music, it could be Nigerian music, or a Chinese music. As long as it's sufficiently engaging, and it's the type of music that people already listen to and already love. If we piggyback on this, behavior change science talks a lot about piggybacking on existing daily activities and daily behaviors, and listening to music or enjoying music is one of those daily activities and daily behaviors that we can piggyback on. And because of its the inherent connection that music, culturally specific music, has for individuals within a culture, we strongly recommend, whenever possible, incorporating music to facilitate greater engagement within health intervention. So the answer is yes. We believe that cultural adaptation frameworks that incorporate music increase the potential efficacy of that intervention in meeting its stated objectives by solving or mitigating the barriers related to cognitive rejection of the intervention.
Thank you very much. One other question for you. As you design programs targeted to children to deliver messages to adults in their lives, do you have any concerns that there might be negative consequences for the children if the adult doesn't want to be bothered or is offended by the message?
That's a fantastic question. And it's very important, because we actually looked in some of our studies, we looked at communication styles. different parenting communication styles, authoritarian styles, authoritative styles, or styles that facilitate the type of engagement that these interventions are more likely to be effective within. And yes, there are some parental communication styles, especially in countries with very high power index, power indexes where it's more hierarchical. It can be more challenging. But that said, what we've tried to do is develop interventions that also are appealing to parents. I'll just give you an example. So for our interventions here in America, we target African Americans, but the children that we are targeting, they don't, if you remember the video I showed, it showed a video of Dougie Fresh. We've also have videos of other old school artists. Now, we could have chosen to use, to have artists develop the music who are well known to the children. But we deliberately chose to use artists that are well known to the parents. And so the music is child friendly and it's appealing to the youth, but the artists that we chose are artists that are beloved often by parents in the inner city America. Dougie Fresh, Chuck D, DMC from Run DMC. These are all artists that are very, very well loved. And so when a child engages in the child-mediated procedure that we recommend, the parents, even parents who are more hierarchical in their communication styles, they're already intrigued and fascinated by an artist that they recognize and they love, who their child is talking about. And so that begins the discussion and breaks down some of those power indexes that was raised by the question. And so my answer to that is yes, there are some communication styles that reduce the impact of child-mediated health communication. However, in the design of the intervention, it's important to incorporate elements that you already know would be appealing to the parents, because that can hopefully reduce some of the resistance to the messaging.
Thank you very much. That concludes our questions for today. I want to apologize to Dr. Williams as well as to our listeners for the challenge. We will post the PowerPoint, the full PowerPoint, with I think the links to the music. I believe we will post the recording, though if our technical difficulties interrupted that, we won't. And I want to, again, thank everyone for their participation, and Dr. Williams for your work and for your agility in continuing despite the technical difficulties. The webinar will be posted on linkscommunity.org. The next webinar will be on Thursday, May 23rd from 9 a.m. to 10 a.m. Eastern Standard Time, and it will be on sodium reduction, the Chilean regulatory experience, making healthier food environments. This is quite exciting. Chile has one of, if not the most advanced nutrition policy in the world, and we'll all look forward to hearing from it. Thank you again, Professor Williams, for your work and for sharing it with us, and for all of the participants for your participation. All the best.